Hello, my name is Don Weiss, and I am a medical epidemiologist with the Bureau of Communicable Disease for the New York City Department of Health and Mental Hygiene. Today I'm going to present the topic of disease surveillance with a focus on syndromic surveillance. You might be familiar with this New York-centric image in which all of New York City is largely detailed and the rest of the country is not defined. I've adapted the cartoon to represent an epidemiologist's view of surveillance. This is only to say that surveillance comes first, as data is the bedrock upon which many public health programs are built. This is a definition of surveillance. It's actually a combination of two textbook definitions. I'd like to highlight several distinctive components. One, that surveillance is ongoing. Two, that it includes the analysis, interpretation, and dissemination of data. And three, that the goal here is to either prevent disease or promote health. Public health is not specified in the Constitution. Therefore, under the 10th Amendment, these powers are reserved for the states. States may delegate some powers to local jurisdictions so that they may pass laws specific to their needs. In New York City, there are laws about window guards, which would have little or no relevance in other parts of the state. Local laws can be stricter but not less so than state law. This is what is known as home rule. The New York State Sanitary Code and the New York City Health Code set forth the diseases and conditions reportable by law. The Health Code also grants public health police powers in order to prevent the transmission of disease. It is important for you to understand and use these terms correctly, because the media frequently does not, and the public will invariably become confused. Exclusion is when a person is prohibited from a specific activity. It could be work or school, or even from taking a flight. A chef with salmonella is excluded from work. Isolation is formed of sick individuals to prevent disease transmission. Persons with active TB are isolated. Quarantine differs from isolation in that the individual is not sick, but has been exposed to a communicable disease. Isolation and quarantine may be done at home, in a hospital, or another location. There are several methods of conducting surveillance. In communicable diseases, it has been primarily a passive system of mandatory reporting from providers and labs. Many states have moved to electronic clinical laboratory reporting, ECLARs, which has vastly improved reporting in both quality and quantity. Other systems are employed mostly as the situation dictates. We've used sentinel surveillance for influenza and Zika. There are many types of surveillance systems. If you go to the CDC webpage, you'll see that there are pages and pages of the different types of systems. The ones that we'll primarily be concerned with today are notifiable diseases and syndromic surveillance. This is just a short list of some of the uses of surveillance data. We use it to detect outbreaks, to identify patterns of disease transmission so that we can learn more about diseases in order to prevent them. It allows us to follow trends over time. We are often shifting resources to combat the emergence or the increase of certain diseases. Helps us identify populations at risk so that we can do more prevention. And it can also be used to evaluate efforts at prevention and control. So what is syndromic surveillance? I think we first have to understand what a syndrome is. It's a group of signs and symptoms that occur together that produce a pattern that help characterize a particular abnormality or disease. So it's probably easiest to understand it by using some examples. Kawasaki's disease, generally of young children between the ages of 6 months and 6 years, that has a certain classic presentation. There's conjunctivitis, which is inflammation of the eye. There's red, swollen tongue, dry, fissured lips, enlarged lymph glands, and then the skin can, and often does, peel or desquamate. It is important to recognize Kawasaki disease because it's associated with abnormalities of coronary artery disease. Another syndrome that has been in the news of late is acute flaccid myelitis, or AFM. Acute flaccid myelitis is the acute onset of loss of the ability to move one or more than one extremity. It's associated with viral illnesses. The one that is most often spoken of is enterovirus D68, although that is not the only virus that's been associated with AFM. So how does reportable disease or traditional surveillance compare to syndromic surveillance? The system in use, eCLARS, requires several things to occur. First, the patient gets sick. Then the patient seeks medical care. The provider has to obtain a diagnostic test, which, as you know, for influenza and other illnesses is not always done. And then the specimen is sent to the laboratory, in which the laboratory then performs a test. What you're looking at on this slide is a plate in which a stool culture in which salmonella has grown after 24 hours. So you see there's inherently some time delay from when the test is taken until the test is complete, which could be as long as a week. Syndromic surveillance, on the other hand, is not based on laboratory tests. It's based on symptoms and perhaps some physical findings. It's much faster. It is not the main system, and it suffers from the fact that all over the country it's operated in different ways so that you can't really combine the data as you can with traditional data. And besides government, there's academia and for-profit organizations involved in this type of surveillance. When we use syndromic surveillance data, we're making a trade-off. Because the data is pre-diagnostic, it lacks specificity. But because we can get it sooner and in hopefully large quantities, it may uncover patterns of disease before traditional systems would detect that. And there's lots of different types of data that are classified as health behavior. They could be from administrative sources. It's preferred that these are automatic and transmitted electronically and in real time. Several events of the 1980s and the 1990s led infectious disease epidemiologists to begin thinking about ways to detect outbreaks sooner. In October 1984, the Rajneeshi cult deliberately contaminated salad bars in the Dalles, Washington, in an attempt to affect a local election. In April 1993, there was a large cryptosporidium outbreak in Milwaukee, Wisconsin, believed to have affected about 400,000 individuals. There was a failure of filtration plant to detect an increase in turbidity and prevent the cryptosporidium from passing through the filters. In June 1994, Aum Shinrikyo planned an attack using sarin in the Tokyo subway. And then about the same time, while the Soviet Union was dissolving, there was concern over their large stockpiles of biological and chemical weapons, as well as what their scientists would do now that they were out of a job. And then, as you know, in September of 2001, there was the attacks that followed the attacks of World Trade, in which weaponized anthrax spores were disseminated through the mail. So the theory behind syndromic surveillance, at least for its use in bioterrorism, has to do with the fact that many of these bioterrorism agents produce a bimodal illness in which there's some nonspecific prodromal symptoms followed by the more severe illness. And the theory was that if you could detect those prodromal illness, because a large number of individuals exposed would be seeking medical care, you might get an advantage of a couple of days, and that would be a big help in trying to prevent illness in those individuals, because at least for anthrax, there is prophylaxis that could be used to prevent severe disease. What you're looking at in this slide is day 0 where the release is, and then 2 to 3 days later, you have the prodromal symptoms, in which the majority of people might show up for health care on day 3 or 4, and then their severe illness wouldn't occur till 2 or 3 days later. So there is a difference of a couple of days there, marked on the graph by the letter T, in which you would have the opportunity to intervene. This is a timeline of the development of syndromic surveillance systems in New York City. Previously to 2000, there were some systems in place, but they were mostly manual systems. And then 1999 was the first system which used emergency medical 911 dispatch calls, and that was followed by the creation of an emergency department system, which was right after the attacks of 9/11, because we were worried about bioterrorism attacks. And that system started very rudimentary. There were 15 hospitals out of the maybe at that point 60 in New York City, It was a paper-based system. We entered it into laptops. We brought the disks back to the health department, merged them together, and then ran a report. That became automated in the fall and early winter of 2002, and then it was followed by the addition of prescription and over-the-counter pharmacy sales, school health. There was a modification of school health system. We included syndromic surveillance in the health code around 2008, and there was an expansion of over-the-counter just a couple years ago, and the most recent system to come on board is urgent care. So this gives you an idea of the amount of data that flows into the health department every day. So for emergency department, there's roughly about 12,000 visits. All the EDs that operate in the city are participating. You see much fewer emergency dispatch calls, pharmacy sales. There are quite a number of those. There are limited drugs that we get. And urgent care is just coming on board now, and we don't have much information on how that will work and what that will contribute as of yet. So as I mentioned, the emergency department system started the day after 9/11. This is the form that we used. We had 30 or so epidemic intelligence service officers dispatched from Atlanta. They did 12-hour shifts in the 15 EDs that we used. They would code each of the visits in one of these categories. They would enter it into a laptop. The disks, we were using floppy disks, would travel back and forth to the health department where we had a whole data center to process that. And then in the months that followed, November, December, we added hospitals. We went to an electronic system, expanded our syndromes, and it evolved into the system that we use today, which is really our flagship syndromic surveillance system. So the data is nearly 100%. I'm sure that we miss some visits on certain days, but we get all hospital data. Some of the hospitals can't report over the weekend, so there are little pockets now and then where we don't have complete data. It is not a very elaborate system. We have a few variables, and I'll show you an example of what the data looks like. The chief variables, or the main variable, is the chief complaint, and then we get ICD-10 diagnostic codes. We get disposition, whether the patient was admitted or discharged. We're starting to get additional information, which we think will be very helpful, such as the patient's vital signs, temperature, blood pressure, or pulse. And then there are nurse triage notes, which we think would be a rich source of information. We characterize these into a number of primary syndromes, the ones that we're interested in for communicable disease, those being respiratory, influenza-like illness, diarrhea, vomiting, and then other illnesses which are of interest to our health department, such as asthma, carbon monoxide exposure, heat, and cold. The latest improvement on the system is that we've been able to get hospitals to transmit data hourly. And while for most of our syndromes this isn't necessary, for things that are evolving fairly quickly, such as an explosion or a major accident, we can get a sense of what's going on as it progresses by hour. So this is a map that shows you where the hospitals are in New York City. You can see that they're fairly well or evenly distributed, although there are some areas in Queens in which there are no hospitals in large swatches, but it is assumed that patients would go to the nearest hospital, wherever that might be. So this is an example of what some of the data looks like. As you can see, there's only a handful of variables. The chief complaint sometimes is a simple word, or one word, or maybe a code. For the most part, the data is complete, though you can see there are some holes where the diagnostic codes are missing. And then we've done a lot to improve the disposition. It had been maybe 40 or 50%, but over the last couple of years, it's improved to near 90%. So what do we do with that data? We use SAS, although we have in recent months converted most of our work over to using R. And we use string recognition. That's where we're looking for chief complaint words, that we've pre-written code to say that this word or this misspelling falls into this syndrome. All our syndromes are mutually exclusive, so you only get placed in one syndrome. And then that is done through a hierarchy where the syndromes that we're most concerned about, we're binning the visits to those if there are words that fall into that category. So let's take a look at how our syndrome coding operates. Here's a visit with what should be fever, with sore throat and cough. Those are the hallmarks of influenza. And then here's another visit here in which you have the word flu-like in there. So these get binned to the influenza-like illness syndrome. In this one, it's just mentioned fever, abdominal pain, and vomiting. So our hierarchy would throw that into the vomiting since it's a little bit more specific than just the fever syndrome. And here's one with diarrhea and vomiting, and that is classified to diarrhea. For those of you that are more interested in the coding, this gives you a little bit more information on how we parse things out. There's the macro. This is the old SAS macro. I'm sure the R macro looks very similar. We're looking at a lot of different variations on words, misspellings and partial words so that we can capture all the visits. And this has been an iterative process such that we're fairly often, maybe once a week, learning some new word or misspelling that we add to the code. That has been less so of late since we've been operating the system for about 18 years. We employ several analytical methods. The main software that we use is called SATscan. It is capable of doing both a temporal and a spatial analysis. In the temporal analysis, we're looking for trends throughout the whole city, and we're using a ratio of the particular syndrome visits to all visits, looking for a particular increase over one or several days. The spatial analysis that we do are both at the zip code and hospital level, and we're looking for clusters in space and time. And then for some of the syndromes, we're using various models to adjust for the season, temperature, and other factors that we know affect disease incidence. And so this just gives you an idea of what happens over time. There's a graph there showing the vomit syndrome. It turns out that norovirus strikes the city at a fairly predictable time each year in early November. And you can see the increases here each November. And then the graph shows you visits by emergency department. This happens to be all visits. So you get a sense of where there's high utilization and maybe not so high utilization. And here we're looking at the various syndromes by age. This happens to be the influenza-like illness syndrome. And you're looking at the youngest age group in that top graph here. And that's usually where the illness starts every year. And there's certainly a lot more illness. And that has likely to do with the fact that an adult may not seek medical care for an illness, whereas a parent is more likely to bring their child to see a physician, and particularly to the emergency room for care. In this slide, we've actually detected a cluster. It's in a single zip code in Staten Island, and you can see on the chart it's listing the various visits. And here's the details of the signal. There were 10 observed visits where it expected less than 2. That happened over 2 days and a single zip code. And it generates a p-value using something called Monte Carlo simulation. And you can see that that is a fairly indicative of something unusual. I won't say much about our ambulance dispatch system. It is the oldest system. It began in the late 1990s. There is a call center that the fire department runs that receives all ambulance dispatches, even though not all of them are city-run. We get a limited number of call types. It really functions as an auxiliary system since ED data is much more informative. So here's a look at what those call types look like. The call type ABDPN stands for abdominal pain. You can see there's calls for something to do with drugs, difficulty breathing. Sick is a rather broad general call type that's used quite often for kids. And as you can see, it's certainly not as informative as the ED chief complaint. So here's a look at some of the trends over time. I think the bottom graph is a little bit more interesting because it's giving calls by time of day, and you can track when there'll be more calls expected. And just to give you an idea of the number of calls, here we are a little over 4,400. So I mentioned the outbreak in Milwaukee of 1993. This outbreak wasn't recognized right away, even though there were reports from pharmacies that their antidiarrheal medicines had been selling out. They couldn't keep them on the shelves. We use it for that same purpose, to monitor antidiarrheal medicines and influenza. It's a voluntary system. It's not codified yet in the health code. There are 3 large pharmacy chains that participate, but only one of them sends us prescription data. And we think this covers between 20 and 25% of the pharmacies in New York City. You may not know it, but there are a large number of small, maybe 1 or 2, or independent pharmacies. It's not all chain pharmacy, and particularly when you get to the boroughs of Brooklyn and Queens and the Bronx. So this gives you an idea of what our over-the-counter medicine sale data looks like. We get these NDC codes, or universal product codes, is which we use to classify or bin the sale into it. We don't get information on the individual. As you can imagine, there's no data recorded. When you buy a bottle of aspirin, we don't know how old you are. We don't know what your zip code is, so we use the zip code of the store. So here you're looking at the dashboard for the over-the-counter medications. This happens to be the antidiarrheal sales. And you're seeing there's a signal here and a zip code. And then you can mouse over any point. Here we're mousing over this point, and it gives you the number of sales. And then we also include whether or not those sales were promotional. We find that a lot of our signals that occur in this system happen to do with the fact that the pharmacies are having a sale, and that's why there's a sudden spike in purchases. And here's our prescription medication. So you can see that for this one we do have a little bit more information. We get the patient's age. The rest of the information isn't all that useful. And we use this mostly for the drug here, Tamiflu, which is an antiviral for a flu. And that helps us as another system we use for monitoring flu and doing surveillance. So here's the graphic for these flu sales, and you can see here that there's a spike beginning in January or so, and then lasting for several weeks until March. This is fairly typical of influenza season, so it fits and aligns with our other surveillance systems. So I mentioned we have the 3 large chains that participate. Here's a store locator map. You can see that there's quite a number of participating stores in Manhattan. And back a couple of years ago when we added those other 2 chains, it really filled out the rest of the boroughs. We were running a system for many years which really was skewed towards Manhattan. But as you can see, we have fairly good coverage in the rest of the boroughs now. But again, we're only about maybe a quarter of all the sales that are not sales, excuse me, of all the stores. We think that because these are the large chain stores that maybe there are more sales happening there. So we may be getting better surveillance than just a quarter of the population. So the next system we're going to talk about is the school health nurse system, school nurse system. As you may or may not know, there's approximately 1,700 public schools with a little over 1 million students. Many of them, perhaps 1,200, 1,300 of them, are staffed by a public health nurse from the health department. There are even nurses in some of the non-public schools. They have a system called the Automated School Health Record System, ASHR. It's a computerized system. It has a pick list of syndromes. And there are somewhere in the neighborhood of about 13,000, 14,000 visits a day by students. It's more visits go to school nurses each day than patients go to emergency departments. And here's a look at what the data looks like. We're getting the name of the school, the kid's child's grade, the zip code, the time they came in, and this pick list. And then you can see temperature is sometimes filled out, and this may be more a factor of whether the nurse actually entered it, or maybe for some illnesses there's no need to check the temperature, so that's why it's not there. So what you're looking at here is the dashboard for school nurse visits. This is the influenza-like illness syndrome. You can see that only 1,000 or so schools reported on this day. We also present percent
Absenteeism. New York schools run in the low 90s for attendance. There was no signal. I think what's interesting here, if you look to the left side of the graph, you're looking at the previous influenza season, and there's a school break in February, and you can see that when school resumed, after that, influenza declined. So this is very important information that we're going to look at more closely over the number of seasons that we have to see when the timing of these natural school recesses, for the holidays occur, and what effect they have on flu season. And does it matter, whether it's during the peak of flu season, early flu season? Does it matter what the strain is? And this may help us with some of these non-pharmaceutical interventions that may be used during a pandemic or a severe flu season.
So I mentioned our newest system is urgent care. At present, we have one large provider that's been sending data for about a year. There have been a number of data transmission issues, and so the data isn't complete, and so we're still trying to work out those kinks. There's a few other smaller urgent care providers that are providing data, but there are very few of those. And they're averaging close to 3,000 visits a day, and we're going to be comparing this system versus our ED system. One of the things they've been working on in the last 4 or 5 years is thinking more about what we can't tell from syndromic surveillance and the things that might be missing. And one of the things that we came across is that unless you predetermine a syndrome and know what you're looking for, you might miss something. And of course, there's an unlimited number of possible syndromes. So how then can we be alert to things that are emerging or new if we don't know what to look for? Well, one of our analysts came up with this idea that we could treat all the words that come in on our chief complaint and look for any words that are new. And maybe that will tip us off that something is occurring that we hadn't seen before. So the system characterizes all the words. Certain words that are very common, articles or pronouns, are tossed out, and then it looks at the recent past and then ranks those. So you're looking at that table there on the slide of new words, and you see often these things that show up that are part of codes are not very informative, but if you look here, you can see that eclipse has shown up, and as you recall, there was an eclipse that was quite popular for people to view, and if you didn't wear the correct glasses, you could suffer eye damage, and it seemed that there were a number of people that showed up with that complaint, whereas that word had not previously shown up. Another use for syndromic surveillance has come in the surveillance for meningococcal disease. Meningococcal disease is caused by the bacterium Neisseria meningitis. It's one of the few diseases in public health in which there is a preventive measure when you're exposed. You can take antibiotic prophylaxis. A number of the cultures of people who have this disease turn out to be negative, and it sometimes is difficult to diagnose and doesn't get reported. So we've been able to scan our chief complaints looking for individuals reported to the emergency department and stating they've been exposed to meningitis or meningococcal disease, or that they're there for prophylaxis. And then we use this information to track back to the putative index case, and very often that's a person who had not been reported to us. And then we can assist with providing diagnostic testing to determine whether the patient is a true case or not. So here's an example in which there were a number of visits that showed up in the emergency room on a given day, complaining of exposure to meningitis, and we did go back and find this case and get the case tested, and it did turn out to be a meningococcal case for which we would have not otherwise known about it had we not been doing this type of surveillance. Yet another use for this type of data, syndromic surveillance in the emergency department, and that's looking for chief complaints or ICD-10 codes in which there's an animal bite, especially if these animal bites are from what we call vector species. So there are certain species in New York City that are known to harbor rabies: skunks, raccoons, and bats. You could see for the period of time that this report came from, there were 43 visits detected. Most of those were from raccoons. 17 of those bites had not been reported to us, so there's certainly things that we would worry about in exposures, and you see the number of them required follow-up. On this slide, we're showing influenza surveillance. The graph on the lower left shows many years of surveillance. The blue line is expected, and then the red line is the threshold above which we would decide that the epidemic or each season had begun. And one of the things you can notice here is this large peak that occurred out of season in May of 2009. That, of course, was the H1N1 season. And then this graph here, which is just for the seasons of 2013, 2014, is a blow-up of a typical season to show you when visits exceeded the threshold, and again, that's where we would say that the season began. So we also use this system for non-communicable diseases. Here we're looking at carbon monoxide poisoning. Now, by law, all these are supposed to be reported to the Poison Control Center, but that does not always happen. And this is an adjunct system to help the Poison Control Center improve their surveillance and look for holes in areas where maybe they're not getting as good reporting as they should. So another non-communicable use of ED syndromic is assessment of extreme heat and cold. This system uses ambient temperature, and although all visits for heat and cold illness are not always coded that way, we certainly believe that we get enough of them so we can get a sense when something unusual is happening. So those of you that were living in the city 15 years ago will remember that there was a very large blackout that happened along the eastern seaboard. We had sent out messages to individuals not to consume food that had been in the refrigerator. Well, what happened afterwards is that we had noticed through several of our systems, that top graph here, that's our over-the-counter system. You can see there's a spike here in sales of antidiarrheal medicine, and then here's our emergency department syndrome. It's a little difficult to see on this, but we blow it up. You can see there's another spike here that went on for 3 days in individuals who were reporting diarrhea following the blackout. So we chose to investigate this using the syndromic surveillance system. It isn't exactly easy to do because we don't have identifying information, so we had to track back through the hospitals to get information about who it was. We conducted a questionnaire. We also interviewed controls who were in the ED at the same time. And this turned out to be a paper that we published in American Journal of Public Health. And what we had determined that individuals eating both leftover meat and seafood from the refrigerator were more likely to come to the emergency department with diarrhea than those that had not. So I mentioned briefly about pandemic influenza in 2009. So here's how the system detected the outbreak. As you can see at the end of April, the first real spike that we saw was in the age 0 to 4, and then there was a very prominent secondary spike in those teenagers that occurred, and then we were able to track it over time and see when it dissipated. In this lower graph, this was able to help us track the severity of illness. So as a proxy for severity of illness, we were looking at the ratio of individuals who came into the ED with the ILI syndrome and what proportion were actually admitted, and compared it to what we know as the baseline. Generally, the amount of individuals who get admitted is far below 1%, and we were quickly able to reassure ourselves that this particular flu strain wasn't any more severe than seasonal flu, which was very reassuring for both city officials and public health officials. So another use of this data, you may recall that a lot of communities were flooded after Hurricane Sandy, and the hospitals closed, and pharmacies closed. And so we were able to detect that there was a large number of individuals reported to emergency departments for certain regular needs, such as oxygen, dialysis, methadone maintenance, and medications. So this helps with emergency planning to make sure that there is adequate access to these resources in situations where maybe the subway system is shut down or there are parts of the city that are not functioning normally. Also during Hurricane Sandy, we were able to see where individuals went because of hospital closures, that individuals went to nearest hospital and where those hospitals were. And this also helps us with emergency preparation. So those hospitals that are going to be receiving increased volume can be made aware of that. So another use of these systems, specifically the emergency department and over-the-counter systems, is to track allergy and pollen season. And you can see here in the graph that we had a fairly significant spike this year associated with that. That helps us prepare individuals by sending out alerts to warn folks to make sure that they've seen their physician for asthma or have refilled their medications. So this is something that was noticed in the emergency department system several years ago, the emergence of K2 or spice. This is synthetic cannabinoids or marijuana. And you can see at this bottom graph where the mention of K2 was fairly infrequently, between 0 and 10 visits. And then in September of 2013, there was a very large spike. So using this data helped us localize the area of the city in which to intervene, and visits to bodegas where this was being sold has happened in these neighborhoods. It also helped us to track how well our communication was working over time. And unfortunately, this continues to be a problem as the drug names change and the areas of the city are also changing. So we continue to rely on this data to help us monitor how this war against synthetic cannabinoids is progressing. So another use that we found is to evaluate or help evaluate the Citi Bike program. So this is showing you the pattern of bike injuries here in blue, and then the pattern of Citi Bike trips, and they follow each other. I don't know if we can say much about this. I think that it's mostly a weather-related phenomenon, but it's something that we're using to evaluate various programs. So Candida auris is a fairly newly discovered emerging pathogen. It's caused hospital outbreaks throughout the world and has been a very large problem in certain New York City hospitals and nursing homes. The New York City Department of Health is tracking individuals who've been discharged from hospitals who are colonized, meaning the organism's on their skin, but it doesn't appear to cause them any harm. But it is a concern should that individual be rehospitalized to present to a hospital for care. So we're able to use our syndromic surveillance system to be able to identify individuals by three factors: their date of birth, their home zip code, and their sex. And about 74% of the time that a person matching that, who is a known colonized Candida auris, when they show up in their system, it's the right person, and then we're checking to make sure the hospital knew about that and implemented the correct infection control precautions. And so we're also piloting this with individuals known to the TB program but have been lost to follow-up as a way to maybe enroll them back in care. We also used our ED syndromic surveillance system during the Legionella outbreak in the Bronx in 2015 to both monitor the progression of the outbreak, and it also helped us do some case finding. We used it in subsequent outbreaks, the most recent one that happened in Washington Heights. The second phase of it, we were able to pick up when that began and help the team investigate. Just some other uses of the system that you may not be aware of is there was a group here at the health department we're looking at where people went for oral health, and EDs generally don't have dentists on staff. So patients presenting there are not going to get the care, and this was an epi brief, and it certainly helped us try to craft messages to the public on where they should go for oral health. So here's an example where the system was used to monitor a public health intervention. These are gunshot wound visits, and you could see that there is a high rate in certain parts of Brooklyn, but over the time there was a decrease that was seen in Harlem and South Bronx. But unfortunately an increase in certain parts of the Bronx. One of the more whimsical uses for the data was this project that was done a number of years ago, in which the analysis of visits in individuals over 18 for chest pain was seen, in which there was an increase here in September of 2004, and it just happened to be around the time that Bill Clinton had complained of chest pain and made a visit to the hospital. So a number of individuals in sympathy, I suppose, also showed up in emergency departments with chest pain. So this is a list. It's probably not complete anymore. I put this together probably a few weeks ago, and we're always adding things of the different syndromes, both infectious and non-infectious, that we use the system for. And there's also a lot of one-off visits. You know, we try to look for acute flaccid myelitis in the ED. There's always parts of the health department asking us, hey, can you look for, disease du jour to see if we can either determine if it's increasing or decreasing, or even get some sense of how frequently the disease occurs based on emergency department visits. So where has Syndromic been most useful? So Syndromic has sort of evolved over time. At the beginning, or in the beginning, Syndromic was primarily used to detect bioterrorism, and there are no bioterrorism events, or haven't been. So then the next thought was, well, can we use it to detect regular outbreaks? And it turns out it doesn't do so well there. Most of the outbreaks that we encounter are foodborne. People don't generally seek health care. If they do, not in an emergency department. It does pick up various clusters, so it is good at that. But mostly it works best for these large seasonal epidemics that occur every year, such as influenza and winter gastroenteritis as caused by norovirus. It also works very well with asthma. Syndromes that are very specific, in which the words are not used for other things. Obviously the word fever can be associated with a number of different illnesses, but something like a gunshot wound or a tattoo, those are very specific terms, so it works better for those. The system also has been useful for situational awareness in an event that's unfolding, such as I mentioned with pandemic H1N1 and the Legionnaire's disease outbreak, Hurricane Sandy, heat waves. And then we've used it for evaluating our surveillance systems, and then trend monitoring and evaluation, such as with our K2 work, and we're looking at both hospitalization overall, and then also those utilization for primary care visits, in which we would want to maybe make it easier or less of a burden on hospitals if we could help divert those visits to primary care settings instead of the emergency department. Well, that concludes my talk. I'd like to thank the individuals of the Syndromic Surveillance Unit, especially Rob Mathis, who helped put together these slides. And I thank you for your attention.